Hi to those who have already joined us. I think we're going to give it just a few more seconds for some others to join. Give it just a few more seconds to wait for our producer to give us the go ahead, get started. Okay, David, I think we're ready. We can get started, and welcome to the Cutting the Anesthesia Subsidy topic, which is of great interest in all hospitals across the country and ASCs as well. And believe it or not, it's of interest to, of course, hospital administration, but it is of interest to anesthesia providers as well. Nobody really wants to have a subsidy or to be dependent on a stipend. So we're going to talk about some strategies for that sustainable coverage and to at least hopefully curtail the subsidy that's needed. So I'm Tim Hanners with Sullivan Healthcare Consulting. My background is in hospital administration and physician and provider recruitment and alignment, physician relations. And so over my years, I've had a good understanding and learning about the needs of the surgeons and other proceduralists, and been doing consulting for about 10 years now. And I am joined with my colleague, Dr. David Young. David, you mind introducing yourself?
Sure, I'm David Young. I am an anesthesiologist, worked at the same level one trauma center for 34 years. Had a lot of experience there in working through the OR and OR issues with the director and team. But also around 25 years ago, founded and helped run a consulting company that focused on these same issues, the how the OR is run, governed, and managing the whole process around OR pre-surgical optimization and those sorts of things. So thank you all for joining us, and we hope to provide some good information.
For sure. So let's get started. I think everyone probably is aware that there's a shortage of anesthesia providers. Even when we're talking including CRNAs and AAs, there's still a shortage for what is needed. Those subsidy costs have more than doubled in the last 5 years. And the hospitals typically and ASCs that are footing that bill. And we all know the reason is because our insurance, are especially the private payers, are not paying what they used to. They have taken a stance that the anesthesia is a cost of doing business, I believe, for the hospitals. And so those two things have collided and caused the issues here. But again, I think you'll see everything in our discussion here today is about collaborating between the anesthesiologists like David and hospital administration, because really the common enemy, let's just be real, is the payers. It's the lack of reimbursements that are needed. So let's be sure that we that. And today we're going to look at really three main areas that will help in this issue. Looking at how do we optimize our financial performance. And of course, we're mainly talking about the perioperative space. And we'll get into that with some real life examples. How do we also enhance the operational efficiency? So our anesthesia coverage models, and are they aligned with our hospital's goals? And again, forgive me, I keep saying hospitals. Of course, I mean anything like an ASC, outpatient surgery centers, et cetera, that have surgery and procedures going on where you need anesthesia. So anywhere where anesthesia is needed. And we mainly focus on the OR, but we are talking about non-operating anesthesia areas as well. So all those neuro locations, everything that requires anesthesia. And then lastly, how do we strengthen the workforce strategy? We have to address the anesthesia workforce mix. How do we handle recruitment? And most importantly, how do we handle retention? Which I know everyone is interested in. There are ways to curtail the locum tenens, which of course makes it even more expensive. So we'll talk about that as well. So David, let's start with understanding about billing and collections. This is a real misunderstood area, especially in hospital administration, where we never had to do the anesthesia billing, right? That was always handled by somebody else. We don't have a lot of understanding into it and not much experience. So why don't you start us off here?
So when we are requested to come in and take a look at the subsidy stipend, the first place we start, and if you're an anesthesia group considering your stipend and how to monitor it or manage it, the first thing we do is recommend that a billing audit by an independent auditor looking at the billing and collections to ensure you're meeting established standards. So you want someone outside the organization who is coming in as a contractor to take a look at all the billing collection processes. You want to make sure that your initial claim submissions, 99% plus, your EOB is matching your contract. That's, of course, increasingly complex with outside contracts, with ACOs, et cetera. So you want to make sure that you're optimizing all of your collections and that your net collection ratio is over 90%. Anybody, if you're an anesthesia group and you're looking to go to your hospital, this is a good way to get a head start on the process and understanding so that when you meet with your hospital or organization, that you can speak with some authority about where you are as you approach the contract negotiation.
I think it's crucial, David, and transparency helps build trust, right? And that is the
Absolutely.
definite starting point. So let's talk about verifying the cost.
So we always encourage any organization to understand their costs and focusing on the blended unit, meaning all your payers. What does your blended unit number look like, including Medicare, Medicaid, and the insured and HMO provider numbers? Because when you want to have a discussion with a hospital, you need to talk about what it costs to run your service. So a good idea is to take all of your costs, including your CRNAs, your anesthesia providers, any overtime you might have, your overhead, your billing costs, understand what that is. And then based on the total number of units that you generate, understand what the unit value you would need to be net neutral. It puts you in a good position when you're looking at the stipend, because that's the differential you've got to make up that the insurers are no longer paying in order to be solvent. So knowing your costs is essential when you're having that discussion. And if I think it's just puts you in a good place to be able to explain what the need is. when we talk about subsidy, we talk about this in a more holistic approach. There are things the hospital can do. There are things that the group can do. It's got to be a conjoined effort. It cannot be one side versus the other. It's got to be us together. How do we drive down the cost and remain good partners? So one of the things that we want to look at, of course, in any group is what is your optimal coverage? Now, in an academic center, you have some restrictions, of course, with residents, et cetera. But in a non-academic center, you have possibly some more flexibility in that regard. You need to understand what the concurrency of rooms is. How many rooms are you running at any one given time? And that's going to also be partnered with the block utilization and room utilization. But it's a good idea to know how many providers you're actually running across the anesthesia spectrum, including the out of OR and all the coverage areas that we now cover. You've got to right size your team model. We always recommend medical direction for the high acuity patients, but at times you may need to expand your coverage, even though you lose some of the reimbursement, because you may not have the physicians to cover those sites, or if you're in a situation where reimbursement is really, really poor, that coverage model may need to be expanded just as necessity to help manage the stipend. Most, 25 states are in opt-out situations where they can use independent practice of CRNAs, but 25 states are not. And so there's a wide variability about how you can manage your current staffing situation. Also, keeping in mind that certain situations won't allow that. And we always view the importance of the care of the patient and doing the right thing as the most important in this consideration.
And David, I want to pause on this slide just for a moment because this one's really important. Most of our audience here, people who have tuned in, probably have a contract with their anesthesia group. That may be a local group, it might be a national group, but it's probably a contract. But this is relevant even if you were employing or considering employing the anesthesia providers, right?
Right.
And I think just to ask the question, David, on that third one, the high acuity patients. I know we're probably talking about, cardiovascular, et cetera. But what's a good example? Because this can kind of get debated around a little bit, right? On what the
Yeah.
anesthesiologist, feel like they need to be covering compared to what the CRNA or even AA might feel confident themselves in
Right.
covering.
So this is important because
Yeah.
part of it goes to culture and what the culture is comfortable with, and part of it goes to factual high ASA patients that that need more care. It's also really important to consider the type of procedures that you're doing, cardiovascular, thoracic, those sorts of things, where you may have either a high acuity patient with a low acuity procedure, or vice versa, that may drive how your coverage plan and coverage model works. And we encourage flexibility, but this can't be mandated from anywhere. It's got to be a discussion. It's got to be a collaboration, and the team has got to come together and decide how they're going to operate going forward. So I can give examples of areas of hospitals that run a very broad coverage model with fairly sick patients in a medically indigent area with good outcomes. So there are a variety of things that you can do and tools you can add to help ensure the safety of the patients.
Perfect. And I think here, David, is also important. We're going to get into this, but this kind of gets right into it, right? We're not trying to prescribe in that previous slide a one size fits all for everything and for every day, right? So you need to have your different models and have a deep understanding of what's going to work best. Is that right?
Yeah, there's that, and you've also got to develop a team. You've got to
Mhm.
develop people who understand the concerns of both the organization, and the organization has to understand the concerns of the team, of the anesthesia care team. So one of the things that I've run into more recently with hospitals is, you know, obviously when you're negotiating a stipend, you look at it differently. Typically in hospitals, obviously, which have call, high acuity patients, emergency cases, ASCs, which are really block simple days, where you may approach that with a different model of looking at a stipend, more of an hourly model with some sort of income guarantee. And similarly with endoscopy, I think that it's very important to look at flexibility in your staff. I've been at sites where we offer these three options. We offer full-time, we offer part-time, we offer part-time without benefits, except maybe malpractice. You've got to have a broad toolbox today that offers flexibility, opportunity for people to work in the environment they want to work in, or you're going to end up with a fairly high, broad number of CRNAs. You need per diem models, you need 1099 models. You've got to have varying shifts. Of course, most everyone does now in 10, 8s, 10s, and 12s to reduce your overtime. Your shifts need to match your block to reduce turnover and problems with the what people call the 3 p.m. witching hour. So all of those things are really important in how to manage your staff. We also really encourage people to use late stage providers and provide them an opportunity to do lower acuity cases. The one of the least complex ways of coverage is is using physicians, because the billing is simple. You're getting the full fee. There's no complexity around, uh, for instance, in a uh, care team model where you're covering more than 1 to 4, you're only getting max of 4 units for the physician covering that case. So you've got to be flexible, and you've got to have varying models in order to reduce your number of locum tenens and thus your overall cost.
I know we've got some questions coming in, but I'm getting them all ready for the end here. We'll have a Q&A moment. But David, let's go through here and talk about how to improve the utilization.
Yeah, so I think that it's important, and as I mentioned before, and I'll emphasize again and again, when we work in the stipend environment, we look at the entire um, OR holistically. And what I mean by that is, in order to reduce the stipend, you have to reduce or focus on optimizing the coverage. And you want to make sure that all the cases get done in a timely manner, but you also have to run your OR like a business. It's got to run efficiently. You need to start on time. You need blocks of at least 8 hours. These short blocks leave gaps and coverage and problems with follow-up. It can disrupt teams because you can be switching from one service to another service. You really want to focus on optimizing this piece. And everybody worries about block utilization. I think it's worth looking at. I think it's important. I think that you have to have requirements around it. But what I like to look at really is, what's your staffed room utilization? We like that to be over 80%. The problem with block utilization is that the rules can modify the results. So for instance, if you had a rule where you could release your block 2 weeks out or 4 weeks out, you could release all of your block except for the days that you want to except the days you're working, which are completely full, have 100% utilization with,
Yeah.
10 releases in a quarter. If you're not looking at that, your block utilization looks great, but you didn't use your room.
Right.
Um, Same day cancellations are something really to focus on as well, because they're costly to the team, sometimes up to $1,000, but they're also costly to anesthesia because we're not that
Mhm.
a fallow provider not billing. It only impairs the total revenue source, which increases your stipend. So that's another key piece.
Mhm.
How do you do this? First, beg your pardon?
No, go ahead.
Um, how do you do this? How do you pull this off? You've got to build a culture. You got to build a culture of collaboration. And we like to start that with an OR governance model that includes physicians, anesthesia providers, uh, key folks from the OR, either OR VP, director, who are the key decision makers, and bring them together and work with them on modifying, managing the block, help them understand what the challenges are of the organization. We talk very frankly here. We consider this the OR board of directors. We put this in multiple institutions, hundreds, and many of them are functioning today, saving money, managing the schedule, managing the OR. But what you're also doing is putting folks into an environment where they're making decisions and understanding what the challenges are for the anesthesia care team, as well as the challenges for the hospital who's facing increasing stipend and increasing numbers of locums, which impair the culture of the organization and really don't help in terms of optimizing recruitment of full-time staff.
Hmm. And David, I think the one in the middle is so important, and where you and I have seen the most success in hospitals achieving the things that we just described is when the anesthesia does serve as a diet, and they're actively involved in helping the performance of the OR. They're no longer thought of as someone who's just sitting on a stool or pumping gas. That they are
Right.
now a co like you said, medical director, co-manager. They're helping to drive performance, and they're actively involved in it.
So we pair them with a surgeon, a
Hmm.
clinically active, not necessarily chief or chair. We
Yeah.
pair them with folks who are working with them side by side. That dyad can really make a significant difference.
Hmm. Absolutely. So this is where we've kind of covered these, but three major categories that we identified. There's always more, but we felt like were sort of the top three categories. Probably another webinar to come on some other issues, but really, again, start with your audit. There's a lot of good consultants and providers of that service. But starting with the transparency and starting off on the right foot, being open to redefining the coverage models and what's going to work. And this isn't something that we've ever done with hospitals where we just made a decree and it happened overnight, right? This takes months in the making. And to David's point earlier, a lot of it depends on your nuances and on your culture. And then really focusing in on improving your actual OR utilization to get the most out of your anesthesia providers, because they don't want to be sitting on their hands either. So we have some questions, David. The first one that came in was, can we elaborate on the interpretation of the breakdown of opt-out states? And I will say that this can be found by a Google search if your state is opt-out or opt-in, but it really has to do with the use of the anesthesiologist and the CRNAs or AAs, David.
Right.
Can you explain that?
Yeah. So I've worked in a number of opt-out states where the CRNAs work independently and, in a variety of different settings. Um, I've worked in hospitals where, the CRNAs are predominantly being used to cover the critical access sites. They're being used to cover ASCs, certain places, GI labs, uh, typically not in a team, typically more in a team model when you're really dealing with very acute ill patients. I have worked in and participated with one hospital that's in the Midwest in a steel town. It's very, very challenged financially. And they're an opt-out state. In an opt-out state, their CRNAs work independently, but have oversight by physicians and collaboration with physicians. The care plan is predetermined based on an interview in the pre-surgical area. It's all organized and managed, and they use actually an observation area where they run all the vitals. Everything is being viewed sort of in a control box, sort of similar to EICU. So it's really, there's a really broad management and process, and it depends on the culture of your organization and what you're hoping to achieve and what your providers are willing to partner with you on.
Yeah, and I think it's important, David, because we talked about that earlier about, every place has nuances, right? Out of If you're an opt-out state is just one of those to take into consideration. If you're in a state like, New York, you don't have some of those luxuries. The other nuances you have to take into account when you're looking at staff coverages, of course, what is your trauma level? Do you have a blend of AAs and CRNAs or just one or the other? Do you have residents that are providing that coverage? That changes the staffing model considerably. And then also, do you have ASCs that you can cross coverage, and take advantage of that? David, I think we've probably got one time for one more question. And that is, this one came in, in-house. This is a good one. In-house call requires paying providers oftentimes for 12 to 14 hours with very little going on. How do you advise hospitals on their need to pay for that service that is very underutilized?
Yeah, that efficiency is bothersome. I agree. The challenge, of course, it depends on what your trauma level is and what you need. I have seen places that have very little in the OR, but they're really paying their providers to cover OB. Some sites have gone to CRNA coverage for OB with physician at home on consult. Now, if you're not in a non-opt-out state, obviously the obstetrician's bearing some of that responsibility. But that is done. And it's about the culture of the organization, what folks are willing to do. It's a necessary evil. I think hospitals are paying for coverage for neurosurgery call now, for orthopedic call, all sorts of urology and other things, all not a value add, unless you're the patient, of course, that needs that care, but not a value add in terms of how do you cover the costs of running the organization.
Yeah. Yeah, that's a tough one. Apologize, folks, if we run a minute over, but these are some really great questions. This one is that they really like the dyad model that we talked about. And it is a great secret. But the question is, what have you seen out there to give transparency where transparency is not existing? David,
Yeah, that's a good question. Because I am working with a group that it's not really a stipend negotiation in this particular case. It's an OR optimization. But the group, as we talk to them, have been totally unwilling to share any financials. However, once you get into paying stipends, it's pretty standard, and it's essentially required, because you do not want to be overcompensating based on the volume of work. So we look at the total number of units billed, and there are standards across that based on the MGMA. What are the total number of units billed, and what reimbursement level are you currently at with the stipend? If you're, exceeding based on the amount of work done, it puts your hospital at risk for overpaying that stipend
Right.
in the face of low productivity.
Yeah.
So it's something that's really got to be looked at and watched. And there is no room for lack of transparency when you're putting 6, 8, $10 million on the table every year.
Right. And you're absolutely right. There are some real stark considerations that justify this. But you're right, David. I mean, a bank is not going to give me a business loan, and I know that we don't want to think about this like a loan. It's different, but a bank's not going to give a business loan without seeing what the business is doing and how it's doing, right? So, but I think to get to that transparency again, being done in a methodical way, very respectful, with the understanding that the anesthesia providers are absolutely essential. You can't be we can't be doing things without them. So I think getting to the transparency, because the common goal is that we're trying to get to a sustainable future. And I think that even, anesthesia providers in hospitals can all agree that the where it is today is not sustainable. That's understood. And so attacking the issues and the problems and realizing this is all about how do we deal with the low and ever declining reimbursement from our payers. So and we wish that there was one hospital out there that we could just send everybody to that's doing it perfectly and you could just do it. But again, there's no such thing, because there's no two hospitals that are like. Your situations are all different. I'm apologize we didn't get to any more of the questions. If you do have some more questions, though, please, you can email that info@sullivanhealthcareconsulting.com, which is, we have the longest email addresses in the business. But also you can feel free to call that toll-free number. Find David or I on LinkedIn, and we'd be more than happy to talk at any time. David, any closing thoughts before we sign off?
No, I think that we all like to think of this as a business transaction, but I can't emphasize to you how important it is to partner together, to understand the culture of the organization and the culture of the anesthesia group, because sometimes changing that culture will change your environment. And by doing that, I think working with folks is really important. It's very challenging when people aren't able to speak and be heard and understand the both sides' concerns. We really encourage that dialogue.
Absolutely. Part of the crucial conversations. Right. More to come on that. Okay. Well, that's all that we have time for in this webinar. We will plan to do some more. And again, we'll try to find a way to answer some of these other questions. Thank you all for participating. David, I know that we had a few folks on here today that we know personally already. So thank you, friends, for joining us. And we will talk more in the future.